day everyone, this is Rana Zahrani, a 5th year medical student from KSAUHS. I will talk about diabetes mellitus in multiple parts, and today we will cover diabetes part 2. These videos are mainly based on ADA guidelines, which is American Diabetes Association, published on 2015. The outline will be diabetes screening, risk factors, and diagnosis. Diabetes mellitus is highly increasing in prevalence. At the same time, there is about 25% of diabetic patients are undiagnosed yet, and about 25% of diagnosed diabetic patients, they already have the complications at the time of the diagnosis. So testing to assess the risk factor for future diagnosis in asymptomatic people should be considered in high-risk people to prevent or delay the complications and to have a better outcome for diabetic patients. The screening criteria according to ADA guideline is divided into two parts, adults and children. For adults, all patients 45 years or more, especially if they are overweight or obese, which means BMI more than or equal 25 kilogram per meter square, or more than or equal to 23 kilogram per meter square for Asian Americans. Second, adults at any age, but they are overweight or obese plus one or more additional risk factor that we are going to discuss next slide. For children or adolescents, we need two things, overweight or obese, which means more than 85th percentile for the age and sex, plus two or more additional risk factors. The age of initiation, the screening for children, is either at age of 10 or at puberty. This is if puberty occurs before the age of 10. So risk factors of adults are, for example, physical inactivity, first-degree relatives with diabetes, especially with diabetes type 2, as we mentioned in the previous video, pre-diabetic people, as we are going to discuss in the coming slides, hypertensive patients who have blood pressures more than or equal 140/90 or on treatment already. If HDL cholesterol level is less than 35 milligram per deciliter or triglycerides level more than 250 milligram per deciliter. Also, high-risk race or ethnicity, like in Native American or especially African American or even Asian American. In addition to that, women who delivered a high-weight baby, especially more than 9 pounds, or diagnosed with gestational diabetes. So the diabetes that occur during pregnancy called gestational diabetes, and this is by itself is one of the risk factors to develop future diabetes. Also, women with polycystic ovary syndrome, any clinical condition associated with insulin resistance, since this is one part of the pathophysiology of diabetes, especially diabetes type 2 as we mentioned, and history of cardiovascular disease. So to screen those patients or those people with high risk factors, we need age more than 45 years with no additional risk factors, or overweight or obese with more additional or more risk factor. So risk factor for children less than or equal to 18 years, one is overweight, as we mentioned, plus two or more of these risk factors. Family history of diabetes type 2 in first or second degree relative. Race or ethnicity, which is the same as adult. Signs of insulin resistance or condition associated with insulin resistance. History of mother diabetes or gestational diabetes during the pregnancy of that child. In screening, we use the same diagnostic test that we use for diagnosis of diabetes: hemoglobin A1c, fasting plasma glucose, and oral glucose tolerance test. If the tests show normal results, then we need to repeat the test again after 3 years or more. But if the tests show pre-diabetic value, then we need to repeat the test after 1 year. This was according to ADA guidelines for screening, the criteria and what to do after that. While on the other hand, screening has some differences between guidelines. For example, if we see here National Institute for Health and Care Excellence, they recommend risk assessment for screening or as screening using self-assessment questionnaire or risk assessment tool for diabetes for adult aged 40 years or more, and for younger adults in high-risk ethnicity who have body mass index more than 30 or who have some comorbidities. Another example for screening criteria is United States Preventive Services Task Force. In this guideline, their latest guideline, which was published on 2015, they recommend screening for all adults who aged 40 to 70 years old and who are also overweight or obese. Now we come to diagnosis. Diagnostic tests are almost the same as screening tests, as we said earlier. They are either A1c criteria or plasma glucose criteria. So we check the glucose in the plasma by different ways, either fasting plasma glucose, which is defined as no caloric intake, at least 8 hours. So this is one. The second one is oral glucose tolerance test. The test should be performed as described by WHO. So using a glucose load containing the equivalent of 75 gram anhydrous glucose dissolved in water. Then after that, by 2 hours, we check the plasma glucose. The third one, which is not included in a screening test, but it is one of the diagnostic tests, is random plasma glucose. This is because this test has to be with classic symptom of hyperglycemia or hyperglycemic crisis. And the random glucose, this means we can check glucose level at any time. But as we said, we have to have the classic symptom of hyperglycemia. So for diagnosis, we have A1c criteria or plasma glucose. For plasma glucose criteria, we check the glucose level in the plasma, either after fasting for more than or equal to 8 hours, or by giving glucose load and checking the plasma glucose after 2 hours. Third one is checking the plasma glucose at any time, but the patient has to have a classic symptom of hyperglycemia. So we talked about plasma glucose level. The other diagnostic test is hemoglobin A1c. Hemoglobin A1c is a specific fraction of hemoglobin A, which is the most common form of hemoglobin in individuals. It's found in healthy individuals as well as in individuals with diabetes. So the point here is hemoglobin A1c reflects the average blood glucose concentration over the past 3 months, which is the lifespan, the RBC lifespan. Other name for hemoglobin A1c is a glycated hemoglobin or a glycosylated hemoglobin, which means glucose in the hemoglobin. The test should be performed in a laboratory using a method that is NGSP certified. It is really an effective tool for screening, diagnosis, even treatment, and important point is for follow-up. Hemoglobin A1c has a lot of advantage over other diagnostic tests. It is much convenient for the patient. So meal issues are not a factor for this test. The test can be done at any time with meals or not, and it is much stable and not affected by day-to-day effect or events. So it's not affected by short-term illnesses or any changes in lifestyle or even stressors. It has some disadvantage. It is much costly than other diagnostic tests. It is not available in any health institution. An important point here is incomplete correlation between A1c and the average glucose test. This means that in some individuals we might have false positive hemoglobin A1c, which means high hemoglobin A1c while it is low, or false negative, which means low hemoglobin A1c while it is high. So let's have more elaboration on that. Hemoglobin A1c reflects the lifespan of RBC, which is 3 months. So normal RBC have lifespan of 3 months. This is 1 month, and this is 1 month, and this is 1 month. So if we check the hemoglobin A1c, and for example, we found it 6% concentration. So we are talking about 2% for each month. So for example, if there is someone who is experiencing heavy or chronic bleeding or have any other form of hemolytic anemia, so this RBC are lost, and hemoglobin stores also will be depleted. So if someone with this specific condition, that shortening the lifespan of RBC, so when we are talking about bleeding or losing blood, we are not talking about RBC that have lived for 3 months. For example, we are talking about RBC that reflects 2 months. Let's say when we check this patient number 2, we got hemoglobin A1c, the same result as patient number 1, which is 6%. So now we are talking about 2 months gave me 6% of hemoglobin A1c, which means first month he got an average 3% hemoglobin A1c. Second month he got an average 3% of hemoglobin A1c concentration. So in patient number 1, in each month he has concentration of 2% only. In patient number 2, he had concentration of 3% hemoglobin A1c. So as you can see, patient number 2 has much higher hemoglobin A1c than patient number 1, but at the end we got the same percentage. So this is when we get false negative with shortened RBC lifespan. So in general, if lifespan is shorter than normal, which is 3 months, we will get false negative, which means low hemoglobin A1c, while in fact it is high, but because it reflects a period less than 3 months. This was an example if the RBC lifespan is affected. Another example is with iron deficiency, for example, the glycation rate is affected, and this will lead to elevation in hemoglobin A1c concentration. So we will get false positive, while in fact it is not high. The glycation rate is increased, so we got increased hemoglobin A1c. And this is independent of glycemia. It depends on the glycation rate. Also, another example is if a patient had a recent blood transfusion, the hemoglobin A1c will reflect to some extent the donor's glucose level, because if this blood transfusion was recently, these RBC are from the donor, so this hemoglobin will reflect to some extent the donor's glucose level, and this might affect the hemoglobin A1c, it might give false positive or false negative. If someone has an uncommon form of hemoglobin known as hemoglobin variant, the hemoglobin A1c test result may be falsely negative or falsely positive. So these patients can be confirmed with lab tests. So now we come to diagnostic criteria. When we do the test for diabetes, we will get some results either from hemoglobin A1c or from the plasma glucose test. These results can be normal or pre-diabetes or diabetes result. So we'll start with the pre-diabetes results. For hemoglobin A1c, it's range from more than or equal to 5.4 to 6.4%. So you can notice here we have 1% to say this result is pre-diabetes result. So less than 5.4 is normal, more than 6.4 is diabetes. For plasma glucose level, we have two main units. One is milligram per deciliter. The other one is millimole per liter. Both of them are used worldwide, and it depends on which unit you are using. During this video, I will talk and mention mainly milligram per deciliter. So fasting plasma glucose for pre-diabetes, they will have a result from more than or equal to 100 to 125 milligram per deciliter. Or 2-hour plasma glucose on oral glucose tolerance test range from 140 to 199 milligram per deciliter. So as you can see here, we can use hemoglobin A1c or fasting plasma glucose or 2-hour plasma glucose on oral glucose tolerance test to diagnose pre-diabetic patients. For diagnosis of diabetes, we need to have hemoglobin A1c that is more than or equal to 6.5% or fasting plasma glucose that is more than or equal to 126 milligram per deciliter or 2-hour plasma glucose on oral glucose tolerance test that is more than or equal to 200 milligram per deciliter. Or an additional criteria here is to have random plasma glucose that is equal or more to 200 milligram per deciliter. But here we need to have classic symptoms of hyperglycemia or hyperglycemic crisis. You can see here these two results are almost the same, but on random plasma glucose we need classic symptoms of hyperglycemia or hyperglycemic crisis. To diagnose patient with diabetes, we need first to do the tests that we explain, either hemoglobin A1c or any one of the plasma glucose level. Then we need to confirm that diagnosis. Confirmation of diabetic diagnosis depends on either there is symptoms of hyperglycemia or no. If there is symptoms of hyperglycemia, we need one result above the diagnostic cut point. If there is no clear clinical diagnosis, so we need two results that is above the cut point using a new blood sample for confirmation. The second test, it can be the same as the first test or using different tests. In either way, we need the two results to be above the diagnostic cut point for diabetes. If we did two different tests and one was normal and the other one was high, so what we do with this? So we did diagnostic test number 1 and it was high. Then there is no clear sign or symptoms of hyperglycemia. So we did the second diagnostic test and it was normal. In this case, what we do, we repeat the diagnostic test that it was high again, and the result will be one of the two. Either it will be high, so this is lead to confirmation of the diagnosis, or it will be normal. And this means that we need to repeat the test again in 3 to 6 months. So at the end, we need either 2 tests that are above the diagnostic cut point of diabetes, or clear symptoms of hyperglycemia or hyperglycemic crisis with one test that is enough if it is above the diagnostic cut point of diabetes. Here is the result of impaired glucose test, which means pre-diabetes, and here is the result of diabetic patient. As you can notice here, for the pre-diabetic, we don't have a result in random plasma glucose level, because to use random plasma glucose level, we need clear symptoms of hyperglycemia, while pre-diabetic patients, they don't have clear symptoms of hyperglycemia, since they don't have real hyperglycemia. They have more than normal glucose, so we call them impaired glucose test, not normal and not real hyperglycemia. In summary, diabetes mellitus should be screened in all adults and children with risk factors. Diabetes can be diagnosed by either hemoglobin more than 6.5% or fasting plasma glucose that is more than or equal to 126 milligram per deciliter, 2-hour plasma glucose during oral glucose tolerance test, or random plasma glucose with clear symptoms of hyperglycemia if they have more than or equal to 200 milligram per deciliter or more than 11.1 millimole per liter. Here are the references for this video. Thank you for watching and have a nice day.